I'm Dr. Manjiri. I'm an ART consultant from Pune, and I'll be speaking about killing two birds with one stone, Inositol Isomers. PCOS is just like a Rubik's Cube. It is a complex heterogeneous disorder with multifactorial pathologies. You go on and on and on to correct everything, and it really drains you out. So, but we are peace-loving people, so rather than killing two birds with one stone, let us feed two birds with one scone. And the scone we are talking about is inositol isomers, and our birds are hyperandrogenemia and insulin resistance. So basically in the olden era, killing two birds was a really Herculean task. But now, with advent of technology, the same things can be done by just pure voice commands. With innovations in pharmacological sciences and medical technology, however, have we really progressed while handling our hyperandrogenemia and insulin resistance from our age-old khazana of metformin, or is there anything else to offer? Let us see. So today we shall discuss insulin resistance and hyperandrogenemia. Metformin, is it the lost hero? Inositols, right from physiology to rational therapy. MIDCI combination, is it the way out? And the latest 2019 evidence on inositols. So Song et al. Published in 2016 the pathogenesis for PCOS, in which he found out that insulin resistance is the main culprit in PCOS irrespective of BMI of the patient, which causes hyperinsulinemia, theca cell proliferation leading to hyperandrogenism and PCOS. Unfortunately, nobody yet knows the exact cause of PCOS. Approximately 50 to 70% of all women of PCOS, both lean as well as obese, have some degree of insulin resistance, which probably contributes to the hyperandrogenism in PCO. So let us see a head-to-head comparison between an established insulin sensitizer metformin, which you have been using since 3 decades or so, versus just a dietary food supplement, inositol, who claims to give a tough fight to the metformin. So let's go to the basics. To understand this, let us see the insulin signaling transduction pathway. The insulin binds to its receptor and forms the insulin receptor substrate complex, which enters intracellularly, which stimulates the phosphatidylиnositol 3 kinase. This PI3 kinase stimulates the glucose transport 4 receptor, which is nothing but a security guard. So whenever there is excess of glucose, the glucose-gated channels are opened and there is utilization of glucose and conversion from glucose to glycogen happens. Now, the metformin and inositols have a similar path of action and they act on the similar enzyme. So basically, metformin stimulates the PI3 kinase, while inositols not only stimulates the PI3 kinase but also acts as a precursor for the PI3 kinase in inositol deficient states. Metformin has been widely used. However, the Cochrane review of 2012 stated that it increases the pregnancy and the ovulation rates. It has considerable amount of decrease in the fasting insulin as well as the androgen levels. However, it has no effect whatsoever on the live birth rate, miscarriage rate, twinning and lipid profiles, which we see are profoundly present in our patients. Apart from this, being so good, it definitely has side effects which are considerable. We all have experienced metformin-related side effects in the form of gastritis, metallic taste, and very rarely acidosis and hepatorenal syndromes. So the evidence says that metformin fails to manage insulin resistance in PCO patients, and it inadequately treats the multifactorial pathologies which are associated with insulin resistance in PCOS. So metformin has been used since last 2 decades, but if you are not happy with a particular option, it's time to think about alternatives. So why inositols? It's very interesting to know, Monestra et al. Have published a comparison among currently available therapeutic treatments for polycystic ovarian, which compares the COCs, metformin, clomiphene, and the inositol group with respect to the therapeutic target on one side vis-a-vis side effects of these medications on the other side. What attracted the researchers most was this particular thing, that the therapeutic target of all types of inositols is similar to its counterparts, but with absolutely no side effects. So as we know, there are mediators in insulin pathway. Insulin regulates the blood glucose through the myoinositol and the dechiroinositol arm. The myoinositol is present in central tissues like the brain, ovary, and the heart, and it is important for glucose cell uptake, while the D-chyrioinositol is mainly present in the periphery, that is the liver, muscle, and the fat, and it is important for conversion of glucose to glycogen, hence present in the glycogen storage tissues. We all have been knowingly or unknowingly eating a lot of inositols in the form of grapefruits, beans, almonds, walnuts, sprouts. It is not found in leafy vegetables at all. So what is inositol exactly? There are 9 isomers of inositol. Thankfully, only 2 are deciphered and the remaining 7 are being deciphered. So myoinositol is a 6-carbon sugar alcohol isomer which belongs to the vitamin B group. It is important for cellular morphogenesis and cytogenesis and for intracellular signaling for the development of oocyte. It improves the in vitro maturation of oocyte as well, and it produces a second messenger for the FSH and uptake of glucose. Its counterpart D-chyrioinositol is nothing but myoinositol is converted to D-chyrioinositol because of the enzyme epimerase at periphery. It provides second messenger for the uptake of glucose and synthesis of glycogen, and hence deficiency of this D-chyrioinositol results in insulin resistance. There is a distinct metabolic and endocrine difference between the PCO and the non-PCO subjects, and what will help us identify is the insulin paradox. What happens is, there is a systemic state of insulin resistance throughout the body except the ovary. So ovary escapes this particular systemic state of insulin resistance. So what happens is, at the periphery, there is decrease in conversion of MI to DCI and a peripheral DCI deficiency, while in the ovary, this increased conversion of MI to DCI occurs as a result of peripheral hyperinsulinemia, and there is a central myoinositol deficiency. So all in all, because of a decreased myoinositol levels in the ovary, it causes oocyte maturation arrest, anovulation, and resulting in infertility. At periphery though, because of a DCI deficiency which results in insulin resistance, it causes either hyperinsulinemia, which presents itself as metabolic symptoms in the form of type 2 diabetes mellitus, hypertension, or metabolic syndrome, or most commonly clinically, cosmetic symptoms like hirsutism, acne, and alopecia. HEMARC found out that there was a 47% decrease in the peripheral levels of D-chyrioinositols and 28% deficiency in the levels of myoinositol in the ovary in lean as well as obese PCO patients. So the missing link now is combination of both inositols. So myoinositol supplementation will take care of the ovary, and the D-chyrioinositol supplementation will take care of the periphery, tackling our two birds, hyperandrogenism and insulin resistance. So are inositol effective in all PCO phenotypes? Let us find out. We'll see the effect of inositols on lean PCO patients. This is a study by Leono et al. The objective was to assess the effect of DCI on concentration of insulin, androgens, and frequency of ovulation in the lean patients. 20 patients were recruited for a period of 8 weeks. The inclusion criteria included a BMI of 20 to 24. Half of them took placebo and half of them were supplemented with D-chyrioinositol. And the outcomes measured include the blood pressure and the BMI, the insulin sensitivity index, and the serum androgen levels. The results showed that at the end of 4 weeks of therapy, the free testosterone level decreased by 73%, while the insulin sensitivity index elevated by 83% at the end of 2 months. Apart from that, 60% of unovulatory women ovulated. There was a significant drop in the blood pressure along with the triglyceride concentrations. Familial diabetes and pre-diabetics showed a much better outcome and response to inositols as compared to non-diabetic women. So the Leono trial concluded that in lean PCO women, the D-chyrioinositol reduces the circulating insulin, decreases the androgen levels, and ameliorates some metabolic abnormalities like increased blood pressure and hypertriglyceridemia of syndrome X. Now let us see the effect of inositols on our obese counterparts. Now this is a study by Benelli et al. 46 patients were recruited with BMI more than 26, and for 6 months, half of the patients were supplemented with a myo-D-chiro combination and folic acid for the remaining half. The outcomes which were studied included again the serum androgen levels, the BMI, glucose insulin ratio, HOMA indices, and along with this, the endocrine parameters pre-therapy and post-therapy were assessed in the form of LH levels and FSH levels. Now, this is the exact result which showed that there was a statistically significant difference or reduction in the LH, estradiol values, free testosterone, fasting insulin, as well as the HOMA index in the study group versus the control group. So this trial concluded that administration of inositols is effective in restoring hyperinsulinemia in insulin-resistant young PCO patients. Do we have Indian studies? The answer is no, because we have huge volume of patients, but unfortunately, we do not publish, or maybe we do not make an effort to collect the data. I tried everywhere to collect the studies. I just found one review of literature by the AIMS department, published in the Indian Journal of Endocrinology and Metabolism by Dr. Kalra et al. What does it say? It concluded that DCI treatment has been found to reduce insulin levels, lipids, and blood pressure in women with PCO. They evaluated various studies and they found out that the usage of inositols was not associated with any adverse effects and was absolutely safe in pregnancy. But this is very important. The ratio may be less important than the absolute concentrations of inositols, and most pharmaceutical preparations provided very low dose of D-chiroinositol. So now we've seen the inositols are acting in some way in obese patients, in lean patients. We've seen various studies. So, but again, what should be the optimum dosage? Because we have representatives coming 4 gram inositol, MIDCI 3.6:1, 40:1, only plain chiroinositol, and the only thing end result is pure confusion. So, we have taken various studies. There are limitations of certain inositol formulations. All brands containing MIDCI which have been studied are 40:1 formulation. But it has been noted that 40:1 is a physiological ratio. At PCOS is not a physiological condition. So we cannot be supplementing MIDCI in a physiological ratio to a pathological case. Unfer et al. Did a trial in which they found out that MIDCI ratios vary from tissue to tissue as well as in health and disease. And this was interesting that in healthy condition, MIDCI was 100:1, while in PCO, it was reduced to 0.2:1. So rather than following a ratio which is not defined, it's better to provide the therapeutic dose of each ingredients. What is the latest data on 2019? Now is there any comparative evidence of right dose versus low dose of D-chiroinositol? So what is this? This is a study published in 2019, March 2019 online, Gynecological Endocrinology. This is by Dr. Nicolas Mendonza. It is a multicentric randomized controlled double-blind study along 6 regions in Spain, which compared the effect of a right dose. Right dose means MI 550 is to DCI 150 versus our 40:1 group. So what was done was 56 patients were recruited in a reproductive age group with BMI less than 30 in 8 centers in 6 regions of Spain, and they were put into a randomized controlled double-blind trial. Half of them took right dose and the other half took our 40:1 dose. All patients were given inositols for 3 months up to the date of ovum pickup. Other than inositols and gonadotropins, no other antioxidants were supplemented, and inositols were stopped after the date of ovum pickup. All these patients underwent ICSI and sequential embryo transfers, some fresh and only 8% in frozen cycles. The outcomes mainly which were measured included the clinical pregnancy rate, miscarriage rate, live birth rates, and the secondary outcomes included the testosterone insulin sensitivity indices. Along with that, the M2 output and the ovarian hyperstimulation rate also were compared. There were 2 things which were significant, the rest all declared non-insignificant. There was a higher pregnancy rate in the right dose up to the tune of 65%, vis-a-vis 40:1 showed a pregnancy rate of 25.9, and live birth rate was 55.2% versus 14.8% in the 40:1 group. So the trial concluded that it causes 3 times higher pregnancy rate and 4 times higher live birth rate, and there was significant improvement in insulin sensitivity and testosterone. However, only 46 patients were analyzed. So more and more studies are required to make any comments about the use of inositols. So it has definitely a value as an adjuvant also. So basically, as an adjuvant, it has been tried in adolescents along with OC pills for regularization of cycle, for managing hirsutism and acne, as an adjuvant to lifestyle modifications in PCO patients, and along with metformin as well, it has been assessed. In adult PCO patients, it has used as an adjuvant to OC pills and along with ovulation induction. As the Greek philosopher rightly says, Socrates has put it that the secret of change is to focus all your energy not on fighting the old, but on building the new. Old keys won't open new doors. So embracing the change is the only way out. However, we understand that there are no Indian studies in this particular thing. The Caucasian population and the Indian population, as far as PCO is concerned, is usually different considering the ethnicity, the metabolic as well as endocrine parameters. And it is for us to keep this theory on one side and practically start using or maybe try using it in our metformin intolerant patients to start with, and then if we are happy, we may choose what we want to do. So inositols seems to have a place as a new key for the old locks. Thank you so much for a patient.